Thank you for joining us. My name is Stephanie Wolf, and I am the Membership Relations Coordinator. It's wonderful to see you all tune in for today's very important panel discussion. We are co-hosting with our sister organization, Population Connection Action Fund. During today's event, we will learn more from community organizers whose work has been impacted by the U.S. foreign aid freeze and the dissolution of USAID. This week marks 1 year since the stop order went into effect. First, a few housekeeping items before we introduce our speakers. As we progress through this panel discussion, if you have questions for our panelists, please drop them in the Q&A box that is found at the screen. We will do our very best to get those questions answered during the Q&A session facilitated by our National Field Director, Lauren Salamiri. And then for any questions we don't have time to answer live, we will provide written responses. In addition, we will follow up via email with a recording of this presentation, the presentation slides, and access to the chat box discussion. Now, to introduce our speakers, I will send it over to our Director of International Research and Policy, Melvine Oyo.
Thank you, Stephanie. Thank you, everyone, for joining us today. We are truly, truly honored and privileged to have you all joining us to just remind ourselves what has happened since the aid on hold. And we are joined with our wonderful and very honored speakers from diverse places. We are honored to have one of our speakers, Jalicia Jolie, who is a public scholar, a writer, and a reproductive justice organizer, and also an assistant professor in American Studies and Black Studies at Amherst College. Thank you, Jalicia, for joining us. Additionally, we have the pleasure of having our speaker, Leshan Kereto from Kenya, an award-winning SRH champion, and who also serves as the chairperson of the United Nations Population Fund, UNFPA, Kenya Youth Advisory Panel. And Leshan is also the founder, Tareto Africa, a community-based organization in Narok County, Kenya, that is widely involved in sexual and reproductive health rights advocacy, mainly focusing on advocating against female genital mutilation, gender-based violence. And Leshan, we truly appreciate that you're able to make it to join our discussion this afternoon, this evening for you. We are also honored to have Bridget Diana Ndagire from Uganda, an expert in HIV programming with a vast experience working on SRH, HIV, gender and youth programming at the national level in Uganda. Thank you so much, Bridget, for joining us to share your experience and your expertise from Uganda. And we are honored to have Martha Clara Nakato, a public health specialist and community development facilitator honed in adolescent and youth health with a focus on sexual reproductive health and rights, HIV, AIDS, gender, and social justice. Nakato has a vast experience in this field, and we are truly honored to have you come and share with us your work. And lastly, we are honored to have Willis Mula, who is a former service delivery coordinator with the orphan and vulnerable children at Akukurunat, which was funded by USAID. And he has a bachelor's degree in international relations and diplomacy, as well as proficiency certificates in program management and engaging young people in emerging issues. And Willis brings on board a vast experience and expertise working with young people who are orphaned and vulnerable in hard-to-reach communities that have been impacted directly by the funding freeze by Trump. So we welcome you all, and we are privileged to have you on board. Thank you so much. I will give you, I'll give each of you 2 minutes of introduction. Just a quick one. Tell us who you are and the work that you've done previously. And to begin us, I will call in Leshan to just share briefly about yourself and your work. Thank you so much.
Thank you so
And
much,
over.
Mel, and to the entire Population Connection team. My name is Leshan Kireto from Kenya, and I'm the founder and CEO of Tareto Africa. Tareto Africa works to ensure that young girls from pastoralist communities like the Maasai community have access to critical sexual and reproductive health and rights information and services. And it's my 8th year in advocacy this year. And I've worked towards eliminating female genital mutilation and child marriage. And I'm glad that we've had the opportunity to partner with Population Connection to deliver some critical help that is life-changing over here. I think this is a timely conversation, and I'm very excited to have this conversation because I've previously worked for UNFPA, who have already also been heavily impacted by Trump's administration. And so I'm glad to talk about these issues, and thank you so much for putting this together. Thank you so much. Back to you, Melvin.
Thank you so much, Leshan. Next, I'll call in Martha Clara. Please take up the mic.
Thank you, Melvin, and good evening, good morning, or just greetings to everyone that has joined us this evening. I'm honored to be here, and thank you to the team that has really organized this. I am Martha Clara Nakato, and I am based in Uganda. I have also been in the advocacy work and policy for the last 9 years, and for the last years, I've been working heavily on adolescent and youth health, and also doing a lot of work that is focused on system strengthening. Currently, I am a convener for the National CSO Task Team, that is a coordinating mechanism advancing the collective coordination of all civil societies in Uganda and ensuring their diplomatic engagement within the health sector. On the other hand, I have been a member of the NGO delegation for the UNAIDS board, and it has been quite overwhelming to also witness at that level of how the US cuts have really affected the UN entities, that even some are at the verge of closing. So this conversation is timely, and I am hopeful that by the end of it, we will have to really have strategic ways of how do we move forward as stakeholders, and how can we ensure that this does not happen in years to come, because this is a matter of life, and we cannot negotiate on people's lives. Thank you, and over to you.
Wow, amazing. What an experience. And we look forward to your sharing as we continue the conversation. Thank you. And I'll hand over the mic to Willis Muller.
Thank you, and good evening from this side. My name is Willis Muller. I've worked with obviously programming for the last almost 10 years. That is since 2015 to date, being supported by various programs, but majorly by USAID funding. Our programs have been diverse in terms of supporting, but majorly the HIV affected or reinfected children. And our main aim has been to ensure that we reduce or eliminate HIV infection among children and especially adolescents from the mother to child. This program has been important not only in health, but also other social determinants of health, including education and other life-changing skills. And with the freeze, or let me not talk about freeze now, with the ending of the funding, because right now we are not funded, and I think that has been clear from Trump. We have seen quite an effect, and this year has been very massive, especially when our children are going back to school, and we can report massive dropout of school and other changing HIV programming, which we are going to see serious impact in terms of increased HIV infection, which I'm very afraid because some of the programs that were there in the community funded by this program are no longer there. So it means we are expecting quite a reverse of the gains that we've been able to make for some time. And I'm glad to be here just to be able to share what has been the experience in the last 1 year and maybe what we are going to experience in the coming years with this cut in funding for HIV programming, especially community programming. Thank you so much, and glad to be here. Looking forward to share a lot. Thank you.
Oh my God, so devastating. We can't wait to to think through what we need to do to fill the gap that is left. Thank you so much, and we look forward to your further sharing. And now I hand over the mic to Bridget. Bridget, can you still hear us? Bridget is connecting or joining us from Uganda. Thank you, thank you.
Good evening and good morning to you over there. My name is Bridget. My name is Bridget Ndagire, and I work with the National Forum. I'm a programs manager there, and I coordinate the young people, youth, and gender at the organization. I have 9 years experience in HIV SRHR programming, and I also have experience around livelihood, because you cannot rule out livelihood when you talk about HIV. So I've implemented several programs in terms of HIV, SRHR, and livelihood. And key of the things that I do is to ensure that community voices are brought at the center where decisions are made. And by this, I ensure that young people in their diversities, key population, young people living with HIV, adolescent girls, and young women are also part of the discussions where decision shaping the direction of policy as well as service provision. So I'll be sharing my experience later on in terms of what has happened and the impact on the community, the marginalized community that I represent. Thank you very much, and over to you now.
Thank you so much, Bridget. Yeah, your experience really speaks to what is currently happening. I'm sure you have been directly impacted, and we can't wait to think through what we need to do as advocates of reproductive health. I know that Dr. Jalicia is meant to be joining us, and if she is not here yet, I will hand over the mic to Lorraine, but when she's here, she will be able to introduce herself and also share her experiences in her work.
Hi.
Oh, she's here. Thank you so much, Delicia, for making it.
Of course.
Yes, you have your 2 minutes of introduction. I did a short introduction of who you are, but yeah, you have 2 minutes to introduce yourself and your work before we delve into the questions of the day.
Absolutely. Well, it's such a pleasure to be here. My name is Jalicia Jolly. I'm an assistant professor in Black Studies and American Studies at Amherst College, as well as the director of the BRAHA Collective, the Black Feminist Reproductive Justice, HIV/AIDS, Equity, and Activism Lab. And much of what we do is focused on bridging high impact, community engaged research around reproductive justice to high impact learning experiences in the Caribbean, the United States, and the broader African diaspora. In general, I teach, write, and work around Black women's health and leadership, health inequity. So looking at how marginalization and inequality gets embodied in individual bodies as well as in communities.
I also do a lot of work around organizing reproductive justice futurisms, which is a gathering that invites us to think about and confront the ways eugenic ideas and eugenic logics have been intervening in how we organize our lives and how we live more broadly, and really looking at the reproductive justice framework as an important guideline for how we can develop strategies and mutual aid networks and broader movements that counter the violence and the inequality that we're experiencing today. And so I'll, happy to share more and talk a bit more about the reproductive justice framework around the right to the bodily autonomy, the right to not to have a children, to have a children, and to raise the children we have and to live more broadly in sustainable conditions where there are enabling environments, including policies, resources, law, basic support, and structures that enable life as opposed to expose us to premature death. So excited to talk more about a little bit about my work in Jamaica and the United States, and glad to be here with all of you. And sorry I was late. I was coming over from a doctor's appointment.
No problem, Delicia. Sorry, get well soon. Thank you so much for making it, even though you had to be at the doctor's appointment. And we look forward to your sharing. Thank you so much. And I will now, at this juncture, hand over the mic to Lauren, my colleague.
Hi, everyone. Good morning, good afternoon, good evening. My name is Lauren Salmieri. I am the National Field Director with Population Connection and Population Connection Action Fund. I'm so honored to be here today helping facilitate this conversation. All of our speakers have such a wealth of knowledge and experience, and I know you've all been touched personally and professionally by this foreign aid freeze. And I'm looking forward to hearing more about your experiences and how you can see our path forward. So my first question today is going to be for Bridget. And Bridget, I think we might have you keep your camera off just for bandwidth issues. You were breaking up a little bit when you had your camera on during your introduction, and we want to make sure we can hear you clearly. So my question for Bridget is, drawing on your frontline and your policy experience, how have these recent U.S. global health cuts impacted the communities you work with, and particularly women, girls, and other marginalized groups?
Thank you very much. And yes, just like any other country, we also received the same, the stop work order that consequently affected the communities of people living with HIV. So briefly, I work with the National Forum of People Living with HIV. This is an organization that coordinates specific cohorts of people living with HIV, including young people, women, and other specific cohorts. So as a result of the stop work order, we were implementing a program that was called the Treatment Literacy Program, and it was funded by USAID. So at that time, the program was helping in ensuring that people are linked into care, people are identified at the community, people living with HIV who are identified at the community have access to life-saving ART treatment. So when this news came in, a number of staffs had to be laid off. Some health workers, most of the public health facility, you would say that 80% of the staff at the public health facility were being supported by donors, and most of the donors, the funds were coming from the US funding. So most of them were laid off at that time, and the country had to revise strategies on how to ensure that there is continued access of services at that moment. This funding, the funding as well as the cut led to reversal of 30 years, decades of progress in HIV programming at country level, because as HIV programming, that we had made a number of gains in terms of HIV prevention, in terms of community participation, in terms of system strengthening, but most of this and the other bad or negative part of it is that as the US funding was cut, even a number of donors pulled out in supporting HIV service delivery. So this posed challenges to the vulnerable community. At that period, we did a number of assessments with support from UNAID and other partners. We did a number of assessments to see whether there is continued access to services or there is interrupted access of ART. So we noted from the studies that we conducted that there was really disrupted access to care in terms of ARVs, because we know our major donor in Uganda for HIV was USAID as well as PEPFAR, and PrEP, condoms, ARV, the prevention methods of HIV, most of them were being funded by donors. And when it came to the key populations, the risk was even, they faced trauma in terms of programming and as well as service deliveries. The drop-in centers where the key populations used to access services, from had to close because they were entirely dependent on the USAID funding. So there were issues around increased stigma and loss to care, which is a non-continuity of access to services. And still, we also felt a number of issues around increased gender-based violence, because as the government was planning, they implemented the integrated HIV service delivery. And in terms of integration, all the services were brought in a one-stop center. And previously, HIV programming was implemented in isolation, like it was another program being implemented at the health facility or the public health facility. So when the services were merged, most of the communities that we serve, the adolescent girls, young women, faced a number of issues around gender-based violence because they had not, they were not prepared well to disclose to their spouses and even disclose to the communities. So in this mode of integrated HIV services, people's HIV status were being disclosed to the community, and it was a systematic system-led disclosure, because communities will get to understand, people who come to health facilities will get to understand the reason why these people have to come to the facilities. And still, as we look at service delivery, the quality of service delivery also had to shrinken, because at previously the ART clinics, the ARV clinics were implemented by specialized service providers. But then when it came to the merger, remember that the specialized clinics were being supported by health workers who were being funded or who were employed by donors, all donor-led programs. So at that point, now we had to come, when the communities came to the integrated kind of model, there were issues of capacity, there are issues of still as a result, the capacity and also the limited human resource to health, which in the end leads to the increased turnaround time at the health facility. And yes, many mothers, young people had to even lose employment opportunity. This had still a bearing on the livelihood, because the time now they currently still is the model that we're implementing it, but people spend more time at the facility compared to the previous times where there were standalone clinics for specialized care. And still, the US funding freeze has increased the vulnerability of still the marginalized communities, where, because when we talk about the prevention treatments, the HIV prevention programs, all approaches or methodologies that were being implemented at that time. When we talk about PrEP was majorly funded by the USAID. And currently, Global Fund is trying to fix in some funds on how to ensure that we continue with this preventive approach. But in the end, you'll see there's still the vulnerable young people, key population that are still being pre-exposed to HIV, and because of the poverty as well as the inequalities in terms of negotiation on how to engage in sexual relationships. As I speak currently, the countries, we have a stock out of condoms, and still last year, because still of the funding cuts, the country experienced the stock out of third line treatment for over 3 months. And most of the people who were on the third line treatment had issues of hypertension, but now they had to be switched to the DTG drug that still was causing an effect or an impact on their life. So this, in the end, has really led to a number of risks to the community. And yes, as well as the country is trying to do a number of things to ensure that this is done, but the effect is far fetched than what we thought we had anticipated at the beginning of the funding cuts. And still to add on that, community-led programming that was strengthening treatment literacy, that was strengthening the GBV, supporting the GBV prevention programs, that were supporting awareness on HIV prevention in the community. The funding was halted. And when we, later on, when it was uplifted, you see that they only factored to continue, they only considered to continue supporting direct service provision. And then now the community were being left behind. And the community is being left behind, meaning now there is no better way to engage community in terms of promotion of service delivery, as well as promotion of the preventive methods. And in the end, this, as we move forward, if another study is being conducted in terms of the increased number of HIV prevalence in the community, in the country, you bear witness that now the increase, there will be an increase of new HIV cases in the community, which is also an impact to the recipients of care, but as well as it has a risk on how best the country is going to program for the increased number of the increased number of new patients who are HIV positive, all who are found HIV positive.
Bridget, I'm so sorry. We need to move forward with a couple of other questions so the speakers have time to answer. But I think you've touched on so many important points, and one that leads really well into the next question for LaShawn. Bridget, you talked about how there was no way to foresee how incredible this impact would be and how widespread it would be. And LaShawn, our question for you is that in the year since the so-called U.S. foreign aid freeze, what are some of the quantitative and qualitative impacts on your healthcare systems and communities that you've seen, like service delivery and workforce capacity and things like that?
Okay, thank you so much. And again, thank you so much for this very important conversation at this time, because it's been a year of shock, not only shock, but also life being affected, especially from a health perspective due to the ending of the funding from USAID. And what we've seen in terms of service delivery is looking at the impact that USAID had when it comes to the health service delivery in Kenya. We've seen that close to 40% of health service provision that was being given has been reporting, 40% of them have reported health interruptions, which have heavily affected some of the many important outreach services like immunization, like access to medical supplies that were originally being supported by USAID. We've also seen disruption in access to treatment and prevention services for HIV and TB. And this has caused healthcare service delivery to change from preventive to crisis-driven, where now we're not only talking about prevention, but now we are quickly trying to catch up with the crisis that has come with the funding cut. And this has also really heavily affected the healthcare workforce, where we saw that previously, directly and indirectly, 41,000 healthcare facilities around the country were being supported by USAID and PEPFAR. But then we've seen close to 11,000 healthcare workers have had their jobs lost, or also right now are at risk due to the funding cut that came. And this has heavily affected marginalized communities like the Maasai community that I'm coming from, and pastoralist communities who heavily dependent on some of these services. And many of the people who are affected were community health workers, who are very critical when it comes to prevention and creation of awareness about information on maternal health care, and also information around HIV and TB. Data clerks have also been affected heavily. And we've also seen guiders and counselors, peer educators being affected. And this has caused a big rift between the community and healthcare. There is a big rift between now the linkage that was there before is now huge. And therefore, there is flow of information that is very limited. We've also seen the medical workers who have remained being supported are heavily overworked and burnouts due to the heavy amount of work that they have to do. When it comes to HIV and AIDS and adolescent sexual and reproductive health, which was heavily affected, we've seen a reduction in access to some of these testing facilities and the commodities that are needed for testing, and also the uptake of people coming in for sexual and reproductive health rights is becoming very difficult, because then due to the cutting of funding, we are no longer able to provide targeted and adolescent-friendly sexual and reproductive health rights to young people, including young people living with HIV and AIDS, young girls and women from marginalized communities, young girls from informal settlements like slums. We've also seen young people from marginalized communities, indigenous communities like my community, miss out due to the big gap that has been created by this. We deliver a critical project funded by Population Connection called Trees for Girls, which in the wake of climate change has woken up to fight against FGM, which is female genital mutilation, and child marriage, that came as about climate change that has really fueled the change of dynamics to the extent that girls are being forced out to be married off due to the increased death of cattle, and therefore the need to replenish. And therefore this has caused many girls to drop out of schools, and the many organizations that used to provide scholarships are no longer providing scholarships and sponsorship for these young girls. This has caused dropouts, And an organization like Tareto Africa may not be able to sponsor everyone. But then when they drop out of school, they miss out on critical information about their bodies, about their menstrual cycle. They miss out on information that they need to live up to their full potential. We've also seen morbidity being affected, especially around chronic conditions like TB and HIV and AIDS, where we've seen that there is disruption when it comes to consistent uptake of treatment and prevention. And this has caused the reemergence of chronic conditions to be unmanageable right now. We've seen a lot of malnutrition, especially on young kids, and this is leading into even cases of maternal death in PEPFAR and USAID supported facilities. And this is continuing to be affecting communities that have no fault. They did not make any mistake. The existing facilities and the funding that was there was as a relationship that came in for many years. And these children who are suffering and young girls who are suffering had no fault. It was not their fault. And I think my recommendations will be, I think it's about time that we see that we keep off politics out of critical healthcare services and existing relationships that have continued to change lives in Kenya and many other countries. I think we should keep politics out of it, and we should prevent supremacy battles of leaders coming into affecting the lives of many people who depend on these facilities. I also think we need to prioritize healthcare workforce because then it's the one that is heavily affected, because these healthcare workers are not only doing their job, they also have families, and these families have been affected. And they enjoy the step-to-step help of patients who are suffering. And I think we need to see a reinstatement and emergency fund that is going to support some of these healthcare workers who have heavily been affected. I think we also need to shift power and resources to local actors and organizations that are on the ground, so that if politicians decide to fight on their own, it doesn't get to affect service delivery. Some of these organizations that are delivering some of these very important services are like Tareto Africa and many other organizations who are represented here. I think it's about time that we reimagine sustainable solutions such that we are able to have organizations like Population Connection who are actively working with us, being given the mandate to continue with some of these services, away from politics, away from supremacy battles, and away from issues, such that even if a new leadership comes in, they do not get to disrupt the critical work that was being done by the previous administration. Thank you very much.
Thank you, Leshan. That is, you said it all. That was great, and it's great to hear from you. And it is so frustrating that this aid and this support was just stripped away based on political ideology when it ultimately was helping save lives around the world and uphold health systems and develop critical care and all of that. So thank you so much for sharing that and for your strong words. My next question is for Willis. It's great to see you again and to hear from you again and have you with us again, Willis. So my question is that with the loss of U.S. funding, what community-led or civil society or national interventions have proven to be most effective in mitigating the harm of the loss in funding, and what gaps are you still seeing that remain?
Thank you so much. Once again, I'm glad to be here. Having been an expert in the community for quite some time, like I said in my introduction, it's not a freeze for some of us, it's a cut in funding, totally shut down now for a year or so. And some of the things that have been able to come up in terms of mitigating this are very few. The gap seems to be still big, but then in terms of, I think what Leshan has been saying, the government has tried in terms of integrating services that were initially funded by the USAID funding But again, it's still overwhelming to the medical fraternity or the medical team, because all the community services as well as medical aspect of HIV programming, all of them have shifted to the medical team. And even right now, they are on strike. So no services are being given to our clients. It's very, very devastating. We've made quite some steps before, which have proven to reduce HIV infection. Even if you look across, maybe just taking 5 years back, where prevalence was around 4.5, up to last year, we are at around 3.03, meaning the funding has been able to help us in terms of reducing HIV infections, especially in the community, and we really appreciate. But again, that is what I can say about what we've done in terms of mitigating that, in terms of integrating HIV services into other medical aspects. But again, we still have a big gap, because the HIV programming, in terms of the approach that we've been using as a community, has been wholesome. You can say family-centered, not just focusing on that one client, but looking at the whole community, but also the family setup. So with the kind of scenario we are in, even our president, in fact, even having signed some agreement with Trump and saying they are going to fund the government to do that, nothing is happening. So we are not saying because as CSOs or private entities, we are losing funding, but what we are saying is we are not going to realize what has been done, and most of the gains are going down the drain. Because in terms of the prevalence that, in terms of what has been addressed so far in the last 5 years, and currently the emerging issues, in Kenya we call them the triple threat, where we have issues of teenage pregnancy, issues of HIV new infections among adolescents, and issues about gender-based violence or sexual gender-based violence. And right now they are on the rise. And it's because some of the actors that have been on the ground, we are not here because of maybe the resources are not there to help us in terms of addressing the issues. But then I'm looking at even if we've been able to achieve last year 3.03, the next statistics, God forbid, we are going to have a rise in terms of new HIV infections because of the strategies that were there before. In terms of one, like our focus had gone to pregnant and breastfeeding adolescents, the young women there, of course, having not gotten maybe good reproductive health information. So we are trying to mitigate that by trying to ensure HIV positive clients, especially the young girls who are positive or breastfeeding, we ensure that we reduce HIV infection to the children. But having this kind of arrangements not there in the community totally, nothing is happening, because the healthcare providers are just simply giving ARVs, go and take your drugs. Now it's your life, go and do it. So it's a point where we are in a crisis. And looking at also the approach that we used, it's sort of integrated kind of approach, where we're trying to ensure we incorporate even education, the formal education, or even the skilling aspect, where we also introduce the topics of reproductive health, in terms of HIV management. They are totally not there because the team that we're working with no longer, the way Leshana said, they lost a livelihood. They were supposed to be working for the community to be able to help them, but currently they are not able to do that because they are not facilitated to move even in the community to do the same work. So the rise of HIV infection is coming back. And I'm afraid that we had stopped the conversation of AIDS and we might still go back there, which is very painful. We are only talking about HIV that can be managed. And some of the strategies now we are looking at is if you are HIV positive, then it means you cannot infect someone else if you are taking your drugs well. Majorly, we are advocating for if you know U equals to U. If, of course, you have taken your drugs well, your virus has been able to suppress, then if you follow the doctor's prescriptions very well, then you might not be able to infect someone else. But these conversations, we are having them at the community level, most of them, because the doctors don't have time. They are overburdened. They might not have that one-on-one with a client to be able to express that. So we might see the rise in terms of the sexual behavior in the country right now. And of course, looking at in terms of gender, women almost double the population of people having HIV/AIDS. Of course, in Kenya is around 1.3 million. So women have double what men have. And that burden is going not to ease, because when our mothers are having, or our sisters, young girls are being HIV positive, they are pregnant, then if they don't get the quality education that you're supposed to offer to them, then it means they are going to transmit this, I'm afraid, to the children that we are giving birth to the community. So this kind of situation is not going to stop right now unless we have a reverse of that, and we put in mechanisms that will be able to help us have a long-term strategy, because we had a strategy of up to 2030. So when you are cutting the funding in 2025, 5-year strategy going like that, then it means they're not going to realize the milestones that we expected. So for me, as a community practitioner, most of the time, or in my whole life, I'm afraid, yes, the government has tried to do integration of services, but totally not happening, because we can see crisis. For me, where I sit every day, I get calls from institutions. Your children are sending back home because of school fees. Some have dropped off in terms of HIV medication, because we are doing tracking for them to integrate them to care. So if these boys and young girls and women and men in the community not taking HIV medication as then it means you're going to have triple, double, or 10 folds of in terms of HIV infection, which is not going to help us. The way Leshan has said, we don't need to politicize this. We don't need to prove that I'm the president. I can control this world. We don't need to play with people's health. Health is very important. And I usually say, this is a global village. You might try to do things in Africa, and you feel you might not get the impact in another country, it might still get back to us. Of course, I'm international relations by profession, means this is a global village. So people are interacting in terms of movement is very high. So if we don't address a problem in one corner, then it means it's going to spread out to the whole world. So for me, coming to this forum is just to share the frustrations that we have in terms of having ended this funding for us, and I'm still willing to share in any other forum, and we need to do a lot in terms of ensuring that even if we don't restore the full blast that was there, but again, to a smaller scale, how can we be able to support the community interventions that are going to help us in terms of addressing HIV infection in the community, which is a big menace coming because of the current generation, which is very, very productive, I'm afraid to say so. So that is what I can say. Of course, we have $1.6 billion that the US committed to the Kenyan government recently. But how is the funding going to be used effectively to address what was there? Is it just to go to pay salaries, allowances, and yet we are not going to see the impact of the same in the community? So maybe I rest there. I'll address concerns as they come. Thank you so much.
Thank you, Willis. Thank you for sharing that. And yeah, the compounding effect of this ending of the funding really does have ripple effects throughout communities. And I hear a linkage between what LaShawn said and what you said as well. And a piece you each said that I think go hand in hand, and maybe something for the two of you to explore as well. But how can that integrated approach that you were discussing in the education and working within communities to have an integrated approach tie in with the localization piece that LaShawn was talking about? I think those two go hand in hand, and it's great to hear you both talk about that. So my next question is for Martha, and it is that given the hostile political environment that we have toward global health funding right now, that's being promoted by the United States, and also speaks to what our previous speakers have mentioned about, playing president and playing this role of, taking control of people's health when they are not entitled to it. What lessons should policymakers, governments, and advocates draw about how to best mitigate the impacts of this decreased U.S. global health funding? Martha, over to you. Thank you.
Thank you, Laura. And I want to start by appreciating the speakers that have spoken before me. I believe that we all agree on one core thing. Health is life, and health in itself is the heartbeat of any country. So we cannot play politics when it comes to people's lives. So I want to start from a place of reflection, because it's important that before we look out and complain and be the problem children, we always have to look within ourselves. So where I sit, one thing is clear. Africa has suffered very, very many very many health emergencies, challenges. You can mention it. The reality is there is nothing to learn that very many African countries did not know at the beginning. There is nothing to learn. Policymakers, advocates, and everyone, we know what needs to be done. The question before us is all about the political will and the commitment to do the right thing. So as I move to the lessons that we've learned, my call to action is simple. As we leave this call today, we should really be ranged up, more motivated to push our countries, to push stakeholders and ourselves to do the right thing. So the first lesson that we have all witnessed in this funding freeze, and I think all countries know that health security, which is currently very key, lies in true country ownership and sustainable domestic financing. We know that donor dependence is not a way that we can take anymore. So countries, especially African countries, it is sad to note that at the start of these cuts, very many countries had to pull up health emergencies, reaction to move towards health integration without rethinking what can we do best to ensure that there is continuity of services, to ensure that we can protect the gains. And I think the numbers are showing clearly. 2 days ago, the Coalition Plus produced a report 1 year after the US funding freeze and the cuts. It is devastating. Very many countries have rolled back service delivery for people that need to be getting those services. Many have not received those services. So key things that countries can really look at for this first lesson. We need to find ways of how can we diversify our resource portfolios beyond just relying on one heavy donor, and that has been US. So we need to now think about strategic partnerships with the private sector. We need to look beyond philanthropic organization, but also think about avenues of how can the country generate its own revenues, but more than anything, have accountability for the way those revenues are used. Lishak has said something about shifting the power if we want to have things moving together. For me, I just want to emphasize that that lesson, if done right, could be a key way on how countries can move away and start transiting away from donor reliance. I'll move to the second lesson that is very key. At the heart of health is communities. We need to find ways to protect rights of all people. And the reason why I mention this is when you look at the overall portfolio of the programs that the US, the PEPFAR in totality was funding, many of these programs were the heartbeat of community system strengthening. It is where you will find community health workers. It's where you will find things like service delivery models that are community-led and allowing communities to lead and be at the front line of services. It is unfortunate that when the cuts came, they were abrupt, no notice, stop everything, everything gone. And we've seen key interventions like PrEP, access have been affected. When you look at the different differentiated service delivery models for very many countries, all of these have been affected. It's a rollback because if you're to look at social inclusion, this is where communities, we the key affected populations, are able to meet our people where they are. All these have been disrupted. So again, my call to action, and one thing that we need to push, especially activists, advocates, is we know till now communities are not legitimized in very many countries. Community-led responses are not aligned to the national health systems. So as we move forward, you cannot negotiate when you're not aligned to the system. And these are systematic issues that we need to address collectively, and we need to push through to be able to move forward collectively. The other sad lesson for me that was also very interesting to learn along all these aspects, and also the interactions and engagements that I've had with a lot of people, it unpacked a gap that very many countries have not been deliberate to strategically prioritize what needs to be saved. So a key lesson for countries, if we want to hold our health security, countries need to move towards reinforcing and protecting what must be saved. As a woman living with HIV, it's very unfortunate that the US has to pay for my ARVs and my country is not able to pay for that. It is a shame. So for the advocates listening in, these are things that we need to start pulling up and say, things like HIV treatment, the state should pay. It is your obligation to do that, to protect the lives of people. So politics aside, doing the right thing. We've also seen that when it comes to core things of like the health system in general, the supply chain, very many countries were not deliberate on this. And we've seen this is where issues of the overall supply chain being affected. If you look at the Africa region, Uganda, my own country, Kenya, Botswana, it was crazy. And then you're just wondering, okay, but this is the lives of people. So how do we again have those negotiations as we move into how much should donors hold when it comes to critical things like the supply chain, the commodities, and all that. And I just want to end with two things that, again, for me, it is personal, and I know for very many people it's personal. The speakers who spoke earlier, they clearly said it. We need to protect the rights-based approaches and people themselves, because at the heart of health, it is the people. We have seen that when these funding cuts came, they were clear. I want to believe that it was already orchestrated. They knew what they were doing, highly informed by the anti-rights movements. You can think about it in that way. If you look at the programs that were heavily affected, key population programming, women and girls, reproductive health. So this is for me, it's personal, and please forgive me if I am stuttering in all ways. If I have to just say, I need counseling, and that service is gone. So we need to find ways as countries, as policymakers, to rethink the laws and policies that we have in our different countries and how they limit people from accessing services. But more than anything, for us to protect the continuity of services. I keep on using us because I know you could have a father who is the president, who is the politician. These are bedroom conversations that we can have, such that when we head to the policy table, we are banging those tables and we're moving together. But again, it requires evidence, and these are things we need to do. Issues to do with stigma and discrimination are still increasing in very, very many countries. Many countries still criminalize key populations, the LGBTI community, the sex workers. So for countries, it's about how do we move together without leaving the whole country behind? And I think where we are right now, we need to speak more humanness into our policymakers, for them to understand that these are not issues about politics. These are not issues about, they keep on saying Western agendas. No, these are issues about the lives of people. And we exist, and we need to address these issues collectively. The other last thing for me that I just want to end with is around evidence-based programming. And this is where the challenge lies. Because if you look at everything that has happened within the countries with the cuts, most of the programs that were stopped yielded high impact, though being low cost. The assumption would have been that very many countries would have taken on those basic programs. programs like community supporting for like health education, health promotion. And now with all that gone, countries are still not stepping in to realize that these are the things we need to safeguard. So I just want to end by a reflection of one of the researchers that I read recently. It's a new paper for Africa. It's a new paper from last year at the time of the funding freeze, and then the African Union projected of how a country is doing with their funding landscape. And that was a paper they issued in April 2025. When you look at the year 2001, many African member states committed to the Abuja Declaration, highlighting that we will fund a 15% of that. It is 2026. As of last year, only three countries, Rwanda, Cape Verde, and then also South Africa, that had met those targets. For other African countries, they are below 10. Some are at 5, some are at 4, some are at 7. So it is timely that for African countries that have been heavily impacted by these funding cuts, to know that every country has its sovereignty and interest, and they will always front their people. President Trump has clearly made it clear, America first. Mm-hmm. Can we move towards African countries fronting themselves and their people first? And that means swift ways of moving and doing things, allowing the evidence that we have learned over the years to inform our priorities, but more than anything, to inform the funding landscape if we want to move through. I want to end by saying we have learned protecting rights-based approaches is key. Community leadership and community-led responses are key as we move forth, but more than anything, country ownership and financing. I submit. Thank you.
Thank you, Martha. Yeah, and I'm again lots of themes that are coming through from all of our speakers today. Political will and commitment. How does the political will match with localization and integrated approaches to local programming? And I think that last point about, investments in health systems strengthening, now that there is this huge gap, how can countries meet those metrics to strengthen their own health systems and safeguard them against situations like this that hopefully will never happen again? But I think that this was made clear that anything is possible with the funding cuts from the Trump administration. So recognizing we only have about 10 minutes left, Dr. Jolly, I would love to ask you our final question today. And I think it also ties in very nicely to the conversation that Martha was just saying about protecting rights and the importance of rights-based programming. Despite these ongoing political and funding barriers that countries are seeing and that are happening within the United States as well, the fight for reproductive rights remains paramount. And so how do laws, policies, and social norms intersect to shape the outcomes for women and girls?
Thank you so much for that question. And my esteemed co-panelists, thank you so much for just naming the conditions and sharing your calls to actions. I hope we can collaborate and stay in touch after this, because I'm just really inspired by the work you're doing. And thank you, Pop Connect, for inviting us to have this conversation at this important time in our history and in our global moment. So first off, I just wanted to back up and say, everything resonates with the context that I'll be speaking from, based in the US, doing work, both research and community-based organizing in the Caribbean. Particularly, I'll be talking about Jamaica. And one thing that I want to step back and say is that for all the reasons that all of you just named, like aid withheld is not just funding withdrawn, right? It's futures foreclosed. And so it undermines individuals and entire communities. It harms entire generations and countries. And so I'll be speaking from a reproductive justice lens in practice, because that is asking us to decide collectively and urgently, which lives and futures are we willing to fight for and what that means for this time. Because we know that when the US withdraws global health assistance, it loses far more than influence, right? It's losing credibility, moral authority, it's losing lives. And so, first, for all the reasons that were named, right? So, first, communities lose trusted infrastructure that often took decades to build, right? So, community clinics, peer education, HIV counselors, midwives, we're seeing outreach workers who were crucial, especially in implementing the work for women and girls on the ground in the Caribbean, who are deeply embedded in these local worlds, right? These are not easily replaceable. So when funding is cut, knowledge disappears, trust erodes, prevention collapses, and long before any crisis shows up in epidemiological data. One of my co-panelists mentioned that this will be worse. HIV rates will be worse. Second, the U.S. loses the opportunity to support locally led community-based responses that have consistently proven more effective than top-down biomedical interventions alone, especially from external forces that don't have the knowledge to be defining, often don't have the knowledge to be defining local agendas. So there's a need to that was mentioned, the need to shift power and resources to organizations on the ground. Absolutely just want to reinforce that. And importantly, there's a loss of, this reinforces a dangerous message that women's lives, particularly Black, queer, poor, migrant lives, are conditional and expendable, not worthy of the basic investments. That's a dangerous message to send, whether it be implicit or explicit. So the message does not only stay abroad, it comes home. And I want to make very clear the connections locally and globally so that we understand that we are living in a further global connected world. And so these have reverberating impacts in our local spaces from Jamaica to Kenya, beyond to the US, right? And so it comes home, and what I think, especially, I think many people don't know if they not have the understanding that divestment overseas mirrors the divestments domestically, and the same logics that justified cutting global reproductive health programs, HIV/AIDS services, life-saving healthcare, also justify restricting care at home, right? Which is why global solidarity is incredibly important, and it's necessary to, undermine the acceleration of preventable deaths that we see happening right now. And so historically, we know, as it was described, like when funding drops, the consequences are immediate and devastating. Maternal mortality increases, TB and malaria resurge, trust in public health institutions erode, decades of progress get undermined. In the context of Jamaica, where I work, what this looks like is on top of, a Category 5 hurricane that hit in October. And so we had the ongoing withheld healthcare, undermining healthcare systems, and important community-based work on the ground. And then you had a Category 5 earthquake, hurricane that created immense damage, had reverberating effects on healthcare systems, and complete hospitals were wiped away in key rural areas, and, further creating strain on community-based services and organizations that were already experiencing the deep inequities and precarity of not having the funding they need to provide basic provisional services and care. So now imagine that a new crisis on top of crisis. So we're seeing multiple overlapping crises. We're seeing HIV intervention and research pipelines being disruptive. We're seeing, community-based models, the very backbone of PEPFAR's success, is being sidelined at a moment that there's heightened destruction from climate disasters. So from a reproductive justice lens, law and policies never operate in isolation, right? They are animated by ideologies, politics, social norms, leadership. Many of these decisions that determine whose health is supported and whose suffering is rendered acceptable. And so really loved what you just shared, all that you just shared, Martha, when you were talking about health as a life and health as a heartbeat of anybody's country, of any country. Absolutely, right? And when we see that, when we see sort of the way health outcomes, and especially reproductive outcomes, are never shaped by law and policy alone, right? They're produced by the informal regulation, the decisions of what not to invest in, what to divest from, everyday social life. And so laws have been made, laws may determine whether abortion, contraception, or HIV care is technically legal, but policies determine who can actually access this care, and whether whether seeking that care is safe and legible or survivable. So in my research and community-based work, I have seen how Caribbean women, particularly Jamaican women, have transformed HIV and reproductive health work by centering care, mutual aid networks, and survival that is rooted in an understanding of of interdependence, right? Approaches that are rarely received the sustained funding even before the cuts, right? But delivered durable outcomes, right? Proven outcomes. The scientific public health epidemiological data documented this already. And in many communities I work in, women are navigating reproductive decision making in contexts shaped by a lot of surveillance via law and moral surveillance, right? Criminalization and economic precarity all at once, on top of the sort of disaster responses, as well as on top of the sort of crisis management of withheld funding and care. And so even when the services exist on paper, right, like we have stigma, we have classism, we have fear of exposure or punishment that keeps many communities from accessing the care, right? And so what reproductive justice teaches us, I think, across these contexts is that, choice without conditions is an illusion. And you cannot talk about reproductive rights without talking about housing and food security and transportation and, immigration enforcement, borders, militarized borders, et cetera, and the ability to really care for the safety of communities and their futures as well. So I think when we even think beyond Jamaica, just to wrap up, globally, we see this clearly in what was described. We see this in the restrictive abortion laws and the deep attacks on reproductive freedom. We see this in anti-gender ideologies, right? The austerity-driven funding cuts, where, women and girls experience these intersections, not just as abstract policy shifts, but they're really shaping the embodied harms, right? So delayed care, forced continuation of pregnancies under circumstances of harm, untreated HIV, unsafe childbirth, and the criminalization for survival decisions in contexts of, poverty and overlapping inequalities. And so this isn't, when communities are excluded from PEPFAR negotiations, when data is extracted without consent, when the aid is continued to be withheld, as well as ideological attacks that undermines people's basic access to resources in healthcare, right? That is willful abandonment. And so I think what a reproductive justice lens does for us is that understand that there is a possibility of a future that is rooted in our shared humanity rather than, withheld care and structural violence and militarized dominance, right? Where we can build community. We have been building community in all the ways and need to amplify that with this integration. We lose it, the sort of we can translate scientific breakthroughs into equitable impacts with political will. And we can make these connections locally and globally so that we know what's happening in Jamaica, what's happening in Kenya, Zimbabwe, and other parts in the US South, Texas, in Atlanta, that there are connections and that there is an ethical grounding that says that health is not a privilege of citizenship or geopolitics, but is a human right, which is what reproductive justice teaches us, that this investment is not neutral. It's a political choice that determines who lives, who's left behind. And at a moment when trillions are allocated towards war and surveillance, withdrawing support for global health reveals our priorities with brutal clarity. And this is where we are.
Thank you.
So communities are stepping in where states have stepped back, and I appreciate the space to recommit and get a sense of what's happening in our relative spaces.
Thank you, Dr. Jolly. That felt like a mic drop. It was everything you said really resonated, and there is such a theme throughout what everyone shared, beyond the devastation of what the experiences are, but this is an issue of political will. Health is a human right, and we need to keep pressure on our politicians and our elected officials, whether it's in the United States or in a different country, to make commitments to do the right thing and to protect the health of their citizens, of all communities, not of select communities. And I appreciate us being able to have this space today to hear that common thread and to, like you said, recommit to our support and our commitment for this issue. So Dr. Jolly, LaShawn, Martha, Willis, Bridget, thank you so much for giving us some of your time today. Thank you to Melvine for organizing us today, and to Stephanie for working with our members and our donors to bring us all together. If you're feeling really fired up by what our speakers said today, I certainly am. We're going to put a link in the chat, and I believe there will be a slide on the screen as well. If you want to take action to pledge to fight for her, to reach out to your members of Congress, you can fill out the petition that is linked in the chat box. We are so excited to continue the fight for her, to continue building our power in support of reproductive health and rights. And we hope that everyone will join us in this fight. So thank you again all for your time today. Thank you so much to the speakers for sharing with us. We know that it is time, it's energy, it's emotional labor to be here, and we really do appreciate the energy that you've given us today. So thank you, everyone, and I hope you all have a wonderful evening if you are based hours ahead of us, and afternoons and mornings to those who are in the US. Thank you so much.